Okay, let's dive in. You brought us a really fascinating review article today.
I did. It gets into the nitty-gritty of exercise and atherosclerosis.
Right, so our mission is to sort of unpack that, pull out the key insights for everyone listening. We hear all the time, exercise is good for your heart, but this source seems to go way deeper.
Exactly. It looks at how exercise directly impacts the plaque buildup inside your arteries. Atherosclerosis.
So, beyond the general benefits we know about, what's actually happening in there when we move? That's what we want to figure out.
Yeah, and the source really sets the stage first. Atherosclerosis, that plaque buildup, it's a massive global health issue, a main driver of heart attacks and strokes.
And even with treatments we have now, like statins, they help, but they don't solve everything.
That's a key point. Even with good medical treatment, a lot of people still face what's called residual risk. There's still chance of problems.
Which is where something like exercise comes in, as a non-drug approach.
Precisely. It's a powerful tool to add to the mix. And the source makes a really important distinction early on. It talks about plaque regression versus plaque stabilization.
Okay, regression versus stabilization. Break that down for us.
Sure. Regression means the plaque actually gets smaller in volume. You can sometimes see this with imaging tests inside the artery.
Like it shrinks.
Yeah, it shrinks. But stabilization, that's maybe even more important. It's about changing the plaque's composition, making it less likely to break open or rupture.
So changing what it's made of to make it safer rather than just smaller.
Exactly. Think thicker protective caps, less of the unstable fatty stuff inside. The source suggests this stabilization might be the bigger clinical win.
That makes sense. A stable plaque, even if it's there, is less dangerous than a fragile one.
Right. It's often the rupture of those unstable plaques that triggers the heart attack or stroke.
So let's tackle the shrinking part first. Can exercise actually make these plaques regress, get smaller? It sounds tough.
It is tough. These things build up over a long time. But yes, the evidence suggests structured exercise can lead to modest regression.
Modest. Okay. What kind of numbers are we talking?
Well, one trial mentioned, Saintex CAD, looked at patients with stable heart disease doing supervised exercise for a year. They saw, on average, maybe a 5 to 10% reduction in plaque volume.
5 to 10%. Doesn't sound like a miracle cure, but is it significant?
Surprisingly, yes. This is where it gets really interesting. When researchers pool data from multiple studies, these meta-analyses, they find that even these small reductions link up with a pretty significant drop in cardiovascular events.
Really? How much of a drop?
Potentially around 15 to 20% lower risk. So that small shrinkage seems to pack a punch clinically.
Wow. Okay, that's a much bigger impact than the percentage might suggest. But, who gets these results? Is this for everyone?
That's the important caveat the source brings up. A lot of these studies showing regression were done with higher risk patients, often in very controlled supervised exercise programs.
So not necessarily your average person going for a jog on their own.
Exactly. Whether you get the same effect if you're lower risk or exercising unsupervised, that's less clear. It's something to keep in mind. Generalizability is still a question.
Okay, fair enough. So regression is possible, maybe modest, but still beneficial. How does exercise actually do this? And how does it achieve that stabilization we talked about? What are the mechanisms?
Right. This is the fascinating part. Exercise seems to work on multiple levels inside the body and the arteries. One big one is inflammation.
Inflammation. We hear that word a lot with chronic diseases.
Yeah, chronic low-grade inflammations like fuel for atherosclerosis. Exercise acts as a potent anti-inflammatory. It dials down those inflammatory signals, like certain molecules called IL-6 and TNF-alpha, that promote plaque growth and make it unstable.
So it's like calming the fire inside the arteries.
That's a good way to put it. And at the same time, it massively improves the health of your endothelium.
The endothelium, that's the inner lining of the blood vessels.
Exactly. Super important layer. Exercise helps it produce more nitric oxide, or NO.
Nitric oxide, right. That helps vessels relax.
Yes. Better vasodilation, which means better blood flow. Plus, NO makes blood platelets less sticky, so they're less likely to clump together and form clots. It's all very protective for the artery wall.
Better flow, less clotting. Makes sense. Now, what about cholesterol? We always link exercise with good cholesterol, HDL.
Absolutely. But the source emphasizes something beyond just how much HDL you have. It's about HDL function. Specifically, something called cholesterol efflux capacity.
Cholesterol efflux capacity. Okay, sounds technical. What is that in simple terms?
Think of your HDL particles as little garbage trucks for cholesterol. Their job is to go to the artery wall, pick up excess cholesterol that's building up in plaques, and haul it back to the liver to be disposed of.
Okay, the cleanup crew.
Right. And efflux capacity is basically how good those trucks are at loading up the garbage.
Mm.
How efficient are they at removing cholesterol from the cells in the artery wall?
Ah, so it's not just the number of trucks, but how well they actually work.
Precisely. Yeah, and research suggests this efflux capacity, the cleaning power, is a stronger predictor of protection against heart disease than just your total HDL level might be.
That's really interesting. So exercise boosts this cleaning power.
Yes, it improves HDL's ability to pull cholesterol out of the artery wall. And studies show this can happen even if your overall HDL number doesn't change dramatically. Plus, exercise makes HDL better at being an antioxidant and anti-inflammatory itself.
So a quality over quantity thing for HDL function. That's a key takeaway. What else? You mentioned other mechanisms.
Another one is building new pathways. Exercise stimulates angiogenesis.
Angiogenesis.
Yeah.
New blood vessel growth.
Yes, especially in areas where arteries might be narrowed by plaques. Exercise can encourage the development of collateral circulation. Think of them as natural bypasses.
So the body creates detours around blockages.
Kind of, yeah.
Yeah.
It helps ensure blood can still get to the heart muscle or other tissues, even if the main route is partially blocked. Foundational studies show this improved blood flow through collaterals after training.
Improving blood supply even with existing disease. Okay, that's powerful. So we have inflammation reduction, better vessel lining function, improved HDL quality, and these collateral vessels.
A whole suite of benefits.
But you said the source really doubles down on stabilization being key. Let's revisit that. How does exercise change the plaque itself to make it more stable?
This is probably one of the most crucial points. Exercise literally changes the plaque structure. Studies using imaging inside arteries show that regular exercise tends to increase the thickness of the fibrous cap.
The fibrous cap. That's the protective layer on the outside of the plaque.
Exactly. It's like the lid holding everything in. Exercise makes that lid thicker and tougher. And at the same time, it tends to reduce the size of the lipid core.
The lipid core is the soft, fatty, dangerous stuff inside.
That's right, the unstable material that can cause rupture if the cap breaks. So, thicker cap, smaller, unstable core.
How does exercise trigger those changes?
It seems linked to cellular processes. The source mentions autophagy, which is like a cellular cleanup system. Exercise might stimulate cells within the artery wall to clear out damaged parts and excess lipids more effectively, remodeling the plaque from within.
And the clinical impact of making that cap thicker and the core smaller, is it significant?
Hugely significant. Plaques with thick fibrous caps are dramatically less likely to rupture. We're talking potentially up to 50% lower risk compared to thin-capped plaques.
50%, that's massive.
It really underscores why these compositional changes are so important for preventing heart attacks and strokes, perhaps even more so than just shrinking the plaque slightly.
That really reframes things. It's about improving the quality of the plaque, making it less threatening.
Exactly. Exercise helps make existing plaques safer, even if they don't vanish completely.
Okay, so given these amazing effects, does the source give us guidance on how to exercise? Like, is steady jogging best? Or those high-intensity intervals? What about lifting weights?
It touches on different types, yes. Moderate intensity, continuous training, or MICT, think brisk walking, steady cycling. That's kind of the standard recommendation.
The usual advice.
Right. But then there's high-intensity interval training, HIIT. Short bursts of really hard effort followed by recovery.
HIIT has gotten a lot of attention. What does the source say?
It suggests HIIT can be particularly good for boosting cardiorespiratory fitness, your VO2 max, and also for improving arterial stiffness, maybe even more effective than MICT for some outcomes, according to some studies.
Better fitness, maybe better artery health with HIIT. Sounds good, but is it safe?
Yeah.
Especially for people who already have heart issues.
That's the crucial question, and the source addresses it. Studies, like one called ROGMO, showed HIIT could be done safely by patients with stable coronary artery disease under supervision. However,
There's a but.
there's a but. Caution is definitely needed. It's likely not suitable for everyone, especially people with really severe heart problems, like very low ejection fraction, meaning the heart pumps weakly, or those prone to serious heart rhythm issues, arrhythmias.
So it really depends on the individual's health status.
Absolutely. And sustainability is another factor. HIIT is tough. For long-term adherence, many people might find MICT, or maybe a mix of the two, more realistic.
Makes sense. What about resistance training, lifting weights?
Yes, the source includes that too. It emphasizes that moderate resistance training, alongside aerobic work, is also supported by evidence and should be seen as a cornerstone for prevention and management. It's not just about cardio.
Good to know. Building muscle helps artery health too.
It seems so. Part of a well-rounded approach.
Okay, now, there's a curveball in this source, something called the athlete's paradox. It sounds counterintuitive.
Ah, yes, that's a really interesting area. It refers to findings that some long-term, high-volume endurance athletes, think marathon runners, serious cyclists, sometimes show higher amounts of calcium in their coronary arteries when scanned.
Higher calcium. But isn't coronary artery calcification CAST score usually a marker of plaque and higher risk?
Typically, yes. More calcium generally equals more plaque burden and is linked to worse outcomes. So, seeing higher scores in very fit athletes seems paradoxical. It definitely raised eyebrows.
Yeah, are they exercising their way into harder arteries? Doesn't sound right.
Well, the source discusses research trying to resolve this paradox. The key seems to be in the type or characteristics of that calcification. It's not all the same.
How is it different in athletes?
Research suggests that calcium deposits in these athletes tend to be denser, more calcified, often appearing in distinct patches rather than spread diffusely. And importantly, they might be less associated with the kind of plaque features that cause obstruction or instability.
So a different pattern of calcification compared to, say, someone with diabetes.
Exactly. In conditions like diabetes, the calcification might be less dense, more spread out, and linked with more inflammation and those risky, unstable plaques. The type seen in athletes is hypothesized to represent a more stable plaque phenotype, maybe even a form of healing or adaptation to the high blood flow and sheer stress of intense exercise.
So what looks like a bad sign, more calcium, might actually, in this specific group, indicate a more stable, less dangerous situation.
That's the interpretation presented in the source, that the prognostic meaning of SCAC might be different in endurance athletes. It might not carry the same negative implications or could even reflect a protective adaptation. It's complex.
Wow. That really highlights that context is everything. You can't just look at one number.
Absolutely. Understanding the underlying biology and the plaque characteristics is key.
Okay, so pulling all these threads together, regression, stabilization, mechanisms, exercise types, this athlete paradox. What's the main message for people listening? What are the practical takeaways?
I think the clearest message is that regular structured physical activity is absolutely fundamental for cardiovascular health. It goes way beyond just general fitness.
It's directly working on your arteries.
Yes. Combining aerobic exercise, whether moderate or maybe some HIIT if appropriate, with moderate resistance training seems to be the evidence-based approach. It actively helps prevent and manage atherosclerosis by improving plaque stability and overall vascular function.
And it sounds like a one-size-fits-all plan isn't the way to go.
Definitely not. The source strongly emphasizes the need for individualization. What's best for you depends entirely on your current health, your fitness level, any other conditions you have, and really importantly, what you enjoy and can stick with.
So someone stable and low risk might explore HI8 with guidance.
Possibly for efficiency benefits. But as the source suggests, an older person or someone with joint pain might do better with lower impact options like swimming, cycling, or gentle strength training. Consistency is key.
The best exercise is the one you actually do.
Exactly. And this is where healthcare providers and programs like cardiac rehabilitation are so valuable. They can help tailor a safe and effective plan.
So this deep dive really confirms exercise is vital, but it gives us a much richer picture. It's not just about burning calories for the heart. It's about actively remodeling and stabilizing those plaques.
Through all those mechanisms, lowering inflammation, boosting HDL function, building collaterals, and crucially, changing the plaque composition itself to make it less dangerous. It's a remarkably multifaceted intervention.
Accessible, powerful, and maybe still underappreciated for its direct arterial benefits.
Definitely. And it's crucial to see it as something that works with medical therapies, not as a replacement for them. They work best together.
And it sounds like there's still more to learn. The source hinted at future research.
Oh, for sure. Comparing different exercise types head-to-head in specific patient groups, looking at long-term effects on plaque composition with advanced imaging, understanding how genetics or even our gut microbes might play a role. The field is still moving forward.
But the core message about moving more for artery health is solid.
Absolutely.
Okay, so here's a final thought to leave everyone with based on this discussion. How does this shift in focus from just shrinking plaques to improving their quality and stability through exercise change how you think about your own activity goals, or maybe ponder that athlete's paradox again? How something that seems negative on the surface, like more calcium, might actually tell a different, more complex story about adaptation. Really fascinating stuff.